rare but high morbidity complication is stroke. So that's why I was telling you always use microcatheter while doing these procedures. Get a very stable position into the arteries. Take a microcatheter, get it into the artery with safe distance. Understand that there is forward flow. Whatever you're putting is not coming back. Sometimes while wiring or anything, we can cause distal dissection. And then if we're injecting, the flow is not going ahead, it's just staying there. Don't inject particles at that time. Always make sure either you put a vasodilator, get that dissection treated, wait for some time, do the other arteries in the meantime. And but make sure when you are embolizing, you have a very good forward flow going into the gland so that everything you're sending is depositing there. The moment you see a bit of slowing or some amount of minimal reflux, also you have to stop. Don't inject any further. Thyrotoxic crisis, as I said, again very rare. Only more chances in a patient who's already hyperthyroid. Sometimes if you use very small particles, 100, 300, less than 100, small branches to the trachea or esophagus can cause necrosis. So we avoid very tiny particles. It's either 300, 500 or 500, 700 micron PVA particles that we use. Of course, ischemic necrosis is associated with mild inflammation and it can cause some neck discomfort and bit of pain. So that is something which the patient needs to be informed about and will be taken care by the analgesics and anti-inflammatories. And partial hypocalcemia can happen, especially if you do all four arteries. You should avoid that, or maybe even if it's three and the gland was very small, which got stirred, it may take a bit of time to compensate the production of parathyroid gland. So there can be a temporary mild hypocalcemia. So this is one patient who came to us previously treated outside. He was 45-year-old euthyroid patient. Teacher had left hemithyroidectomy. Right side was normal. Small nodules now start presented with a right-sided. Swelling, did not want to do surgery. Already you can see one scar here. May have read online and came to us. So this was the thyroid gland, large 5.2 into 3.4 centimeter nodule, small remnant on the left side, not very big. So this patient was taken up, length was very long, around 7.2 centimeter longitudinally. So 70 cc right lobe, small left lobe. So these are the runs. You can see how we have taken a run of the thyrocervical trunk here. And yeah, I want to show you this slowly. Now this is the thyrocervical trunk has been cannulated. This is the branch which is supplying the thyroid gland. You can see a lot of gland being supplied. Even one more branch is there. The top one is also supplying. So you figure out all the branches which are supplying the thyroid selectively. Then you cannulate that and you can see that this much part of the gland is being supplied by one branch. So this was the inferior on the one on the left, and this one on the right side, this is the superior one. That one I'm playing, this is the superior thyroid artery. Is usually smaller supply, inferior is usually the bigger supply. So you can see the left side also a branch was going, the small twig is going towards the uh, it's a laser pointer, yeah. So this is the right branch, but there's a small branch going towards the left side remnant also. So all of it cannulated separately through microcatheters and then embolization was done. Contralateral, and you can see this is the, in the lateral you are usually able to see the carotid bifurcation. The posterior one is the internal carotid, anterior one is the external carotid. The first branch of the external carotid is the one which is the superior thyroid artery. There's a 10-month follow-up of these patient, and the right lobe has significantly reduced in size, almost 70% reduction. From 70 it is 21 cc if you see, so 30% is left, and left was hardly visualized on ultrasound. Almost 70%, as I said, reduction in volume of the right lobe, and patient is still euthyroid. Second patient, again 48-year-old female, neck swelling, euthyroid patient, large neck swelling, you can see here. CT was done for this patient as some part was going down to the mediastinum. 5 into 5, 5.6 into 5 into 7.7 centimeter, more than 100 cc volume of thyroid gland. You can see some compression and some deviation of the trachea and the esophagus. So this patient, again cannulation, this was done for the inferior thyroid artery, big supply here. So you can see this is near the clavicle, so this is most likely the thyrocervical trunk and the inferior thyroid. The superior thyroid artery is here somewhere, where the bifurcation is, and the external carotid branch comes down. So this was cannulated, embolization was done. Most of the gland was from this branch itself, so this nodule, doing this artery alone in this case was very useful. The left lobe had become, come down nodule volume to 12.1. Again, 90% we had become necrotic. So that's a massive response for the patient. You can see how, the life changes. Cosmetically, it's a big relief. Heaviness in the neck, big relief. Symptoms, tracheal deviation, everything was nicely taken care of.